pediatric patient in the ICU. So we're very pleased to have his input today and hear him talking about sepsis. And hopefully we'll have a very nice facilitated discussion with him after the first 15-20 minutes of the lecture he will be giving. I will let Dr. Lutfi introduce himself again, and then we'll go over the group and hear who's here with us on the link.
Hi guys, thanks Kamal for the generous introduction. Again, I'm Riyadh, one of ICU staff at Riley, been at Riley since 2012. Thanks everyone for joining us today on the second part of pediatric sepsis recognition and management in the emergency department.
Probably can go ahead and start introduction from people in the Zoom. We'll start with Don.
Hi, I'm Dawn Sullivan-Wright. I'm the clinical nurse specialist from the emergency department at Community Health Network.
Very good, thank you. Emily.
Hi, I'm Emily Green, and I'm the nurse educator for the ER at Community Nurse.
Very good. Allison.
Hi, my name is Allison Wilson, and I'm the unit-based educator at Community in Anderson.
All right, very good. And Jamie?
Hey, I'm Jamie Hutchinson. I'm clinical manager of pediatrics at Hendricks Regional Health.
Very good. And I see Dr. Farman.
Yeah, David Farman, emergency physician, Hendricks Regional.
Thank you for joining us. Michelle.
Michelle Rusi, one of the educators at Hendricks Regional Health.
Awesome. Who else did we miss? Okay. Right, very good. So thank you everyone for being here with us today. Erin is back. I will let her take over this and start running the slides. She's way more efficient than myself in doing this.
Okay. Are you sharing your screen?
No.
Okay. Where's your... Okay. Okay. Did you already go through all this?
No.
Okay. All right. So for those of you who haven't been with us before, we'll go through kind of this, just an introduction real quick. I know a lot of you have been with us on all of our sessions, but the goal of this project is just to provide education, pediatric education, and kind of create a community of practice of providers and caregivers to share knowledge and experience. So this is 100% educational environment for learning and collaboration. We will be recording every session. As you guys know, we make those available to those who couldn't make it and all of your other staff. So by participating, you are consenting to being recorded. If you have any questions, just feel free to shoot me an email. Here is, if you're on the live version, then you can get one CME or CEU. So here are the instructions. I can send these out, and it has changed. The event ID has changed from the last one because we're now in a different fiscal year. So I know some people had issues last time. Let me know if you're still having any problems, but this new code should work for a claim code, and you just have to claim it before 11:59 tonight. Here is the disclosure information from our CME department. So we'll go ahead and get started with Dr. Lutfi's talk.
Okay, sorry for the delay, guy. We'll go ahead and start talking today about sepsis, septic shock management. And as the title say, a diagnosis could save a life. And it's actually cannot be more true than this. And we'll go through the presentation, and you guys will hear what you guys commenting about it. Before I start with my case, I have no disclosure. I'm a site PI for a study based in Cincinnati Children's Genomic Study, but we would not discuss any part of this. My case here started with a very brief 2 slides about a 16 years old, actually a recent case, who was a 65 kilo with ALL, presented to our emergency department neutropenic, febrile at 39 degrees with a heart rate 150 to 160. Her initial blood pressure was 84/60. She was breathing 28 times, satting 100% on room air. She actually did have a normal mental status. Her distal pulses were weak, central were thready. She had significant delay in her cap refill. Our initial blood gas was 715 acidosis with significant base deficit at -10. She also noted to kept her CO2 and O2 with the range you like to see. She's anemic with some degree of AKI with BUN at 40 and creatinine almost at 2. Her lactate was significantly high at 12. So as she enrolled, she was flagged, as we heard from last lecture from 3 weeks ago from Dr. Wager about having an initial sepsis algorithm and an alert. So she was alerted as a septic patient, giving her risk factor as she's an ALL patient who's neutropenic and febrile. So she got a 40 ml per kilo fluid boluses on 2 sequence of 20 ml plus 20 ml. She was initiated a broad spectrum antibiotic. I do not have the timing of the how long it took to get the antibiotic actually in. And her heart rate, as noted, is drifted down by about 30 points, and now she has a blood pressure 100/60. She noted to also remain poorly perfused. She had minimal urine output with about similar blood gases, maybe a little bit more PaO2 and some nasal cannula. Her lactate drifted down from 12 to 10. She remained maintaining very well. She was actually taking selfie and sending to her friends. So, and that's usual, not very usual when you have a lactate in digit. And where do we go? What's the appropriate disposition for this child? And also, how do you treat her? Do you treat her as a child? Why she's 65 kilo and 16 years old? Which guideline we follow? Do we follow Surviving Sepsis campaign for adult, who was updated in 2016 as she is merging in a adolescent life, but also she has a body habit the adult have with 65 kilograms. So moving forward from here, I'm gonna just go back and repeat some of the very important slide Brian put last session about why this topic is important and why we're talking about this on and on and on. And I feel we finally at 2019, even in the last 10 years and the last decade, people talking how important is sepsis, and not only in the ICU, not only in the pediatric ICU or the emergency department, it's everywhere. Since Kamal and Aaron tried to log in to this computer, we probably lost 4 patients in the United States from sepsis because we've been trying for about 10 minutes. So it is a scary number. It's 2% of hospital admission in adult and about 10% in the ICU. And I was looking at the pediatric ICU. Recent data is a little bit less than adult, but it is about 8% of patients in the ICU admitted with pediatric ICU admitted with a diagnosis of sepsis. There is 1 million case in the United States, adult plus pediatrics. In adult, we lose about 20 to 25% of this. Not a recent survey, but about a 10 years old survey showed that's only third of our population in the United States ever heard about the word sepsis. Globally, we hear this number scary, it's 6 to 8 million children died every year from sepsis. So the burden is big and we have a lot more work to do. This is just, I think this is an older slide you can find in www.sepsis.com. About 250,000 of American die from septic shock every year. Sepsis/septic shock. As you all aware, Sepsis II tried to take away the word severe sepsis, so that slide was made before Sepsis III. And that number is overcome acute myocardial infarction, lung cancer, and you can see the cancer number go down. So it is a lot of burden on our population to have sepsis. This is a similar slide, just on and on about how important this number. How about pediatrics? I think Brian also mentioned about 75,000 cases per year in the United States of pediatric sepsis/septic shock, 10 to 20% mortality. We have not made Sepsis III definition in pediatrics, so we are waiting and very excited about adult having a little bit better definition, better epidemiology, and that will lead surely for a better estimation of the mortality and the outcome. But we estimate about 10 to 20% of mortality, so a little bit less than adult, but also it's still very high. Higher mortality surely for infant less than a year of old and a patient who have comorbidity. So the burden is big. Length of stay average in the United States for pediatrics about a month, with a cost about $40,000 per case. The outcome data, the short and long term, are lacking. Now with adult having a better definition, we also look for a better definition in pediatrics so we can track our data. I like this study. It is a 10 years old study, and the reason I put this, it is just a study only talked about what's ongoing healthcare implication for pediatric sepsis patient. It go way above my ICU, way above the ER visit. Those kids actually in this study, a lot of them came back after, about a third of them came back to the hospital after 3 months, within 3 months of being discharged with sepsis diagnosis. So very interesting data and more to come. It is wanted. Sepsis is one of the wanted largest killer children of the world. So what we done so far, what the World Health Organization done, finally they start actually comment about how important sepsis recognition and early treatment for sepsis. So this is becoming a more and more a World Health Organization problem. Global Sepsis Alliance also. In the UK, on the left lower part of the screen, you see pediatric sepsis 6. So very nice algorithm for alert, recognition, early treatment. In Australia, sepsis skills algorithm pathway too for ER screening, inpatient, and a time for antibiotics. So it's not only US, everyone working toward optimizing the recognition and the care for those children. And I keep circulating around recognition because I feel this is almost half of the treatment. So we can talk about the treatment for hours, but recognition should be really highlighted as a treatment, not only recognition, because it is very important part. You guys seen this, you guys know it very well. Sepsis, septic shock affect every organ, started from the brain, can present it with altered mental status in pediatric, confusion, affect the lung, affect the heart, affect the kidney, liver, and the hematological. So we may not talk in details about this, but before moving quick to the treatment, I think it's very important to recognize our 6 septic shock pediatric patient. Not only the component of shock is not only the infection. There is always a hypovolemic component. Pediatric patient, when they don't feel well, they don't drink, they don't eat, they become hypovolemic. Cardiogenic component of the septic shock. Our pediatric patient, even we thought they hold a healthy heart, and usually some of them, they may not have as much comorbidity as adult. They actually more prone for some myocardial dysfunction from TNF-alpha and IL-1B. So we should be aware of the component of the cardiogenic shock of the septic shock, and distributive, as we all talk about it all the time. The other component before we move to the treatment, we should recognize cold versus warm, and why this is important, why our patient can be cold, and why the majority of the adult patient, or a good portion, can be present warm with a flush extremity and a cap refill who's actually those cap refill actually it's a flip around. So usually a cap refill less than 2 seconds with a bounding pulses and a low diastolic pressure. Some fair amount of our pediatric patient, they're the other way around. They're cool extremity, they're clammy down, and their pulses are very weak with narrow pulse pressures. And I think that's probably one of the most important area of deciding about what a blood pressure medication we're going to use for these children. And we'll move forward here a little bit with more algorithm treatment. So what we have done so far in treatment. So I put two very well recognized adult guideline. This is a Surviving Sepsis campaign from 2012. It is adult. Going back to my patient, 2016, you may choose as a ER provider to have a child who's 65 kilo to be treated under this guideline. Noted 2012 has subsection for pediatric patients, so we were recognized in the main guideline, and we have some really recommendation in that in the Surviving Sepsis 2012. In 2016, there's really no mention of the pediatric patient. This is a Surviving Sepsis campaign, almost updated every 4 years. So we're looking forward about the 2020 in the next year. But also someone may say, I want to treat this 16 years old with what adult evidence show. And I put this slide on just for a little bit of reviewing adult and see what's the difference between adult and pediatrics. And I'm not going to go down and dip in every single details of the campaign because it's a long, nicely written guideline. But I want to talk about 3 points here. One of them is initial resuscitation. So what we do for adults, at least 30 ml per kilo. So adult decided even in 12 and 16, we give a bolus of 30 ml per kilo. Usually early on, even the guidelines talk about 3 hours. Usually this is going on in 1 hour. They have a nice algorithm to how fast you push it. At that time, no recommendation of normal saline versus balanced solution. That's may change in 2020. But this is a recommendation for IV fluid. We adults recommend also using some dynamic resuscitation marker to target a mean arterial pressure of 65. You can reassess with some simple, like lifting the patient leg to see if you have any response or not. So that's for initial resuscitation. Going down for vasopressin recommendation with a goal of MAP 65 for adult. Norepinephrine remain the drug of choice for adult. And I want to point this out before we move to pediatrics. So first choice is norepinephrine. Epinephrine is okay if we cannot get our target, or vasopressin to reduce norepinephrine. There is not a lot of solid data on both epinephrine in adult or vasopressin in adult. There is nicely written to avoid dopamine in adult, especially with tachycardia. So that's piece in adult. We don't have it in pediatrics. Very similar in terms of source control in antibiotics. So if you have perfect appendicitis, you need to take it out. If you have a port who has a fungal, you need to take it out. And also initiation of antibiotic within the 1 hour. And this is a brief review for adult, and someone may choose to treat the 16 years old who's 65 kilo with what you guys have. And that's pretty much what she got. She got 40 per kilo, so a little bit above. She got early antibiotic, and we saw the number actually was trending a little bit better. Just moving. How about pediatrics? What do we have? We have a really general treatment strategy, including a fluid resuscitation. We'll see a couple of data behind it, not nearly as much as adult data we have. We have some antibiotic recommendation, very similar to adult. We try to control the source. Sometimes not easy when it comes to lines in pediatrics as in adults, and not much you can do in an emergency department when you have actually port, or you have a child who's very complex who has a Broviac, and some monitoring. Also, we have some organ support recommendation. This is back. Actually, Brian talked about this last week. It's a document, about 2 years old document, came from combined work between American Academy of Pediatrics and Children's Hospital Association. It's a pediatric septic shock collaboration clinical pathway in the ER setting, very similar to actually our critical care or American College of Critical Care recommends. So we're going to go through those documents very briefly and look over them. You cannot see the pathway here very well. It's time for arrival. On the right side, I think it's behind it. Behind the screen, it tells us what to do in the first 20 minutes from arrival. So recognition is a big part of the treatment. As you guys see, the first first box, recognize abnormal vital sign, alter mental status, and perfusion. Not very easy in pediatrics. Cannot really emphasize how hard sometimes to have this in a 3 years old who's fighting your nurse to get a cuff blood pressure, or fighting anyone who touched to get really the pulses and cannot tell are we alter or are we, this is just being a 3 years old. Very hard. Then moving forward to diagnostic evaluation, including some lab, identify source of infection, and identify if your patient actually under high risk to be septic. That's put us down still in the first 20 minutes, establishing access and giving some oxygen. Both task is not the easiest. Maybe having some oxygen on is a little bit easier than getting IV. But also IO has a big role in pediatric patient, and we'll talk about it really briefly. Initial resuscitation in pediatrics, we start with 20 ml per kilo, except for children who are known to have congestive heart failure or congenital heart disease. We like to push those volume a little bit faster than 999 because they may take a little bit while, so we can do push and pull. Rapid infuser is acceptable if that's what you guys use in the ER, or pressure bag within. We like it a little bit faster than I feel the algorithm placed there, but the algorithm has about 20 minutes before you have some reassess and the need for potential more volume. Moving forward, sorry, we already discussed those two. So moving forward for the second part, and that's from 20 minutes to 60 minutes. Our algorithm state if your patient have a clinical improvement, then you go to the left side of algorithm, manage as appropriate. If not, we look into second and third bolus in a similar way, push and pull, rapid infuser, or pressure bag. We also like to give attention for our lab, look for hypoglycemia, which more common in pediatric patient, septic pediatric patient and adult, and also hypocalcemia. And now we move forward down if our patient better or not. If not, we call our patient a fluid refractory shock, and we like to hear, look, do we have a cold shock or warm shock? Because our inotropic decision drug of choice may vary. So why reverse warm shock can put us into the adult arm, or norepinephrine may serve us as a really good drug to start between 0.1 to 1 mic per kg per minute. Our cold shock patient will benefit from having epinephrine going, and that's a drug of choice. Although in pediatric, we are not recommending against using a dopamine. Dopamine, till now, it's readily available in the emergency department. Maybe it's easier to mix for nurses. Neonatal patients still get dopamine easy started, so why adult recommend against it. Our second choice, if epinephrine not available for a cold shock, will be a dopamine. They'll put us down into about an hour, and also discuss if this is a catecholamine refractory shock. Do we need a steroid? Do we activate the other arm? I hope by that time, if you do have an ICU in your pediatric ICU in your institution, to be working on the admission. If not, we should have probably start working on disposition for those children, since the time when they start needing more than 1 or 2 boluses. So that's from the clinical pathway in the ER. Very similar. American College of Critical Care Medicine have a practice parameter for hemodynamic support in pediatric and neonatal septic shock. So this is an updated version in a critical care medicine at 2017, updated version for our 2004-2009 document, and has a very similar pathway to AAP and Children Hospital Association made. I like it more, not being an intensivist. I feel I can follow it also very closely, and it's a clear in timing. So when you recognize your pediatric patient at risk or is sepsis or high chance with the comorbidity to have septic shock, we like to start some oxygen and work on the access. Access can be IV or IO as we discussed before. Also here, practical to get actually IV up to 60 ml per kilo within 5 to 15 minutes. But this will be our recommendation too, or what we have recommendation from the American College of Critical Care. Don't forget about your antibiotic in the first 60 minutes. So that's a good reminder. Also look at the glucose and calcium. And that's put me in a slide that's actually in real life. Most of the children, you guys see them more than us, because the children who get better with 1 or 2 boluses, they're not coming to us in the ICU. So most children will improve with the fluid boluses. So quickly be aggressive and give more fluid. So usually the initial is 20 ml per kilo. We like you guys to check always, as usual, you guys do it already, check for increased work of breathing, enlarged liver, or having rails in the lung exam, or increased work of, as we said, increased oxygen requirement, because this is a sign that maybe your pediatric patient not needing the 60 ml. You may get this child actually quicker on a vasopressin if you start having a struggle with the lung. So always we call it the art of resuscitation in peds. Why adults say 30 may work for everyone. In peds, it's very hard. Some kids may need up to 100 ml per kilo versus other may feel like they're getting already overloaded with 40 ml per kilo, and I want to move forward with my initiation for epinephrine in a cold shock or norepinephrine in the warm shock. What's the data behind pediatrics IV fluid resuscitation? Not much, sadly. There is the 1991 paper in JAMA from Joe Carcio. It's really talking about improved survival in patients who receive more than 40 ml per kilo in the first hour of resuscitation. Not a lot of patients. This study was actually repeated. It was hard to randomize kids not getting fluid to getting fluid, but it was really repeated in a way that kids who had aggressive therapy in the community emergency department in the first hour survived better. So repeated in a way that's give us enough room to have some recommendation about early aggressive fluid therapy in pediatrics. It's easy to say get an IV on them. It's very hard to do when they're so dry and septic and they're clamped down and cold shock. So IO, it can be your other saver. We recommend that you guys look for your most experienced nurse in that shift to look at the child and see who can get an IV. Some of those experienced nurse will look and say, I tell you what, I'm not going to able to get an IV in this kid. So may move forward toward getting an IO. And then also you have to look and see who's your comfortable nurse or physician who do the IO in your institution. Anything almost can run through the IV, can run through the IO. It will be a temporary measure till you get some fluid in and get better access in the after. How about push and pull? And my understanding, this is not very common in adult, but for our pediatric patient is very practical. This is a IV bag hanging there with a stopcock and a 60 ml syringe, and from the left you see how we pull from the IV bag and turn the stopcock off to the IV bag and on toward the patient, who's not seen in this picture but will be in the left lower, and then just push toward the patient. And we can repeat this on and on until you get whatever fluid the physician order. That's also, again, it's recommended if you have rapid infuser, you can have now, there is a couple of devices now in the market who can do this for us without taking one of your nurses away from patient care. How about antibiotic? We always refer to you guys to a study from adult from Dr. Kumar. It's almost over 10 years old because it is a solid data. Every hour passed without antibiotic, the mortality in adult septic shock go up. Not very far from pediatrics. So cannot emphasize more how important early antibiotic, not only order, because also it need to be dispensed by pharmacy, come to a bedside and given by the nurse. So this is very important. What recommendation? It's actually, we have some recommendation based on the age and risk factor. So neonatal sepsis, always think about covering all your neonatal bugs. So ampicillin plus cefotax or NGENT can cover your almost all your neonatal sepsis. Acyclovir should be added if you have concern about HSV. Going down, UTI-induced sepsis, we do not like to use the urosepsis word for billing at least. So Rocephin or Cefotax can give you a good coverage. Intra-abdominal infection, always consider adding antifungal and also flagyl for your patient. Neutropenic immunocompromised, vancomycin and Zosyn being used for a while. We're trying to push towards vancomycin and cefepime at this time, giving some data of the AKI. Also, there is vanc and meropenem is an appropriate alternative. If you have source unknown and child without a central line, vancomycin and ceftriaxone is appropriate start. Always have to decide if you're worried about meningitis or not, because your dosing will be different. So that's moved me from the first 15 minutes. After I give 60 ml per kilo, do I have fluid refractory shock? And if I do, I need to go to a second arm, which is start the child on a blood pressure medication. And that's usually not requiring having a central line placed in the ER, but also if this is an area, if the child cannot get an IV or IV very positioning, you may elect to have a available. Dopamine is a reasonable option in pediatric population. In a warm shock, norepinephrine is the drug of choice. And that's what put me actually after to a 60-minute. And I'm hoping by this time also we have a disposition plan from the ER. I'm not going to go into normal blood pressure, cold shock, and with some mixed venous. I think this is a lot of redundant recommendation here. But also I want to highlight, if your patient have a catecholamine-resistant shock, you should consider a steroid. Also evaluate for other etiology, for example, pericardial effusion and pneumothorax. So that's moving down. How do I assess? How about if my pediatric septic shock patient or sepsis patient spending about 4 hours in my ER? We do follow lactate as well. We like urine output. If your child start peeing more, it's always a good sign. Blood pressure is based on your comfort, 15 minutes, maybe every 30 minutes if your child responds and he's doing okay and you're just monitoring. Prefill is a reasonable marker. Also, pulses decreasing in the heart rate in pediatric patient is a good sign, and surely going from altered mental status to more alert is also a sign of response to your therapy so far. And why I'm mentioning all this work, we cannot ignore, despite a lot of controversial, the study done by an ER physician, adult ER physician, Dr. Rivers. And I'm not going to go details on his study, but I think he take a credit a lot about giving us the attention of the early recognition. A lot of time when we try to repeat his study in a different setting, it's say, placing an upper extremity line or targeting hemoglobin or mixed venous, it didn't work the same. But I think the reason they work the same because everyone now giving attention for recognition for septic shock patient and getting early aggressive treatment is the goal. So this is a little bit sarcastic slide, but actually in reality, this is what he did. His goal-directed therapies tell us like, if your patient in the ER after he walk in with one spot or one sign of septic shock, and then the time when he was seen, he was full of those spots, that he is too late, or maybe we are too late of seeing this patient. So similar study, not really similar study, but similar initiative of early recognition was done in Baylor and published in Pediatric 2011. And this is targeted the time of antibiotic, really with only initiative of algorithm and marking the high-risk pediatric patient. Time of antibiotic went down from 130 minutes to 38 minutes. It's great timing to get antibiotic in those sick children. How about other therapy? Other therapy is mainly meant to be for the inpatient ward, including further cardiovascular drugs, mechanical ventilation, renal replacement therapy, nutrition, and also blood purification strategy and ECMO. And we would not be approaching this therapy during this session. Really, to my take-home message, treatment of sepsis is really, really relying on recognition. So early recognition, early resuscitation, early refer is what going to make us able to fight this largest killer for children around the world. And thank you guys for what you do, because you guys making the difference out there. That's all what I have. It's your time if you guys have any question for us.
Yeah. I don't know if you can hear me or not. This is Dr. Farman.
Yeah.
I had two quick questions, and just kind of thinking about our practice in the emergency department. Typically, we're not going to have the central line, and I was watching your slides about pressors on these children. And so if I'm inferring correctly, it looks like the recommendation for peripheral line pressor would be epinephrine in kids, and if you had an IO, levo would be a reasonable option there. Is that a reasonable inference on my part?
Yeah. I'm sorry. I probably should have been slow on those. So epinephrine is our recommendation in a cold shock. So in a children, which a lot of them, they will come with really cap refill of only really 4 or 5 seconds. They're clamped down. They have model extremity, and that's what we call them really a cold shock. And sometimes it is really hard. I think this is what makes the pediatric a little bit different than adult. We rarely have a kids who's having bounding pulses and vasodilation, vasoplagic, who need norepinephrine. That's why we go for epinephrine. In the case you have a teenager who's really got warm bounding pulses, systolic 100, but diastolic is only 30. I think this child deserves norepinephrine. So, but those are not the most common way our kids present. A lot of time, you guys seen them, they're cold and clamped down. So where epinephrine should be a drug of choice.
Okay. Then my other question was kind of more academic or esoteric. Just my own curiosity was, how frequently do you guys use ECMO? It's one of those things that we were seeing more and more of in the adult literature. I'm a little bit too old to have seen it a lot when I was going through training. So it's something that seems like a huge ordeal, but maybe it's not. Maybe it's something where if a child were that ill, it really is not that big a deal. But I just haven't seen it much.
Yeah, very, very good question. And I think septic shock itself in a ECMO for septic shock, it's a big topic. In the pediatrics, we know our data. Finally, we have an area, we have a better data than adults. And I think we have our kids, even the survival for ECMO septic shock lower than the survival for an ECMO and ARDS, ECMO post-op. But it is still at the level that we will offer it for our children. There is about 40% survival in our kids, and we getting better and better on managing them on ECMO. Usually those children, good fair of them will need a VA ECMO, so we're cannulating artery and a vein, which always has a downside. And usually we're going through the neck if their size small, but I think we're more and more. We just recently, our center was involved in a multi-center publication about ECMO and septic shock, and the outcome better than what we expected initially. Still not as good as other ECMO. You guys doing a lot of long ECMO for ARDS. Still not as good, but I think saving 30-40% of those kids is still a huge number for us.
Right. Thanks.
Thank you so much.
Mm-hmm.
Do we have any other questions regarding sepsis, what Riyadh was talking about, really anything, recognition, treatment?
Hey, this is Jamie. I have a question because we're working on an algorithm here at Hendrix for that, and we were trying to decide how many IV start attempts you limit yours to before you jump to IO, or do you have any recommendations for that?
It is a really good question, and from my own, I tell you this, and why the book it tell us limit them to 2 to 3 attempts of an IV. Sometime, if I know my crew, if I know my night, it is a night shift where I don't have anyone who's very comfortable with pediatric patient. I have one nurse who look and said, guess what? This kid is so dry that I can stick forever. I'm not going to get you IV. I think this child should be limited to 1 attempt versus if I'm here and the nurse during a day and I have 4 or 5 nurses who they said, oh, I can get you IV in this case, then maybe this is the one I go for a 3 attempt. So if you are making, I think, an algorithm and you don't want to have this changes between shift, I think you can limit it to up to 2 or 3 attempts of an IV before you go ahead and place IO. I think we should not lose more than 2 or 3 attempts outside the hospital before we go ahead and place an IO, so we can get some fluid and then someone else can look after maybe getting 20 or 40 ml per kilo.
Okay, thank you very much.
Where do you personally usually go with the IO if you are going to take your first attempt?
It is a good question. I honestly and personally, this is what I look at the kids first to see what could I find. I think in this area, like currently, I think we have a few who's really good with the ultrasound, and I feel if they're here, I want to give it a shot. So just get a ultrasound, see if you have a good size bacillic. It won't delay things, but if things really look complicated, the kid is moving and fighting, and we try to hold the arm and there is nothing there, I said, let's call it a day. Go ahead and put the IO. Let's get us 20 to 40 ml, see what's the blood pressure, and then we'll look for an IV. And it is a really tricky question. I like to look for an IV first, but if this is not an option, then we're getting faster and faster saying, well, yeah, you looked in the ultrasound, no good vein. We looked in the arm, no good vein. Let's go ahead and place IO at least so we can start our resuscitation.
Do you usually go, for you personally, do you usually go proximal tibia or do you usually go?
We like the proximal tibia. I feel majority of our group are proximal tibia people. Our transport team, I feel like sometimes they go a little bit to the humerus. You guys been trying some, but if the proximal tibia fell, and I feel in the ER they place more IO than what we do in the unit. I recall probably 3 or 4 IO in the last year only in the ICU when the kids just came from the floor and we cannot get access, and or one time I think we have a 1 IV, but we just needed so much more fluid and we needed to place an IO.
Okay.
Dr. Farman, do you guys normally go humeral head in the ED? Is that?
No, we usually go tibia because it just seems a little easier. I don't know if that's just kind of the way that we were trained 10 years ago on adults. So that's kind of why I asked, just to see if anyone was doing humerus.
Very, very similar. Very similar.
I think there was a question regarding lactate. Yeah, Brittany doesn't have audio. She said, haven't found much evidence around lactate being an indicator for identification of sepsis. What are your thoughts on lactate for recognition of sepsis in children greater than 65 kilos?
Yeah, it's a good question. So with Sepsis II, I think in adult, now you guys all set on a definition of septic shock, including having lactate above 2. In pediatrics, we're struggling to have definition. I agree with her. We know kids who has a lactate clearance better during sepsis management do better. So as a marker of clearing lactate, it's actually very valid. Equally important to checking mixed venous when those kids are very sick in the unit, not in the ER, for us to trend their lactate. As the initial in pediatrics is not in our definition. It's coming. I think it's going to be in our definition to have a lactate check early on. But right now, what she mentioned is right. But we typically get a lactate with the initial gas when they come with suspected sepsis, mainly for a trend, mainly know where we are, but having lactate of 1 in a child who looks septic would not prevent me from proceeding with the algorithm of treatment. Also, having lactate of 10, it will just tell me how sick they are and how behind I am. But very good question.
Do you guys have the ability to get lactates, or is it something you routinely do if you have a septic patient, or not really in the ED? I'm just curious.
For adults, we do it all day long. For kids, I think it's kind of hit or miss. There hasn't been as much adoption of lactate, but we're including it as part of some of our resuscitation quick sets that we have in the ER. So I think that we'll be seeing more of it.
Okay. Anyone else? You're welcome, Brittany.
Hi, just real quick. This is Allison from Community Anderson. On the image, going back to the IOs, the training that we use, it says that for children that you can use distal femur. Is that not correct?
No, it is correct. I honestly have not used the distal femur ever in my life, but it is correct. I don't know if you guys get your training to train on it. Our proximal tibia being the first place, and then either go to distal tibia all to the arm. But I think we had 1 or 2 physician who placed the distal femur. It's not wrong. It just this is what I think the image didn't show it. You're right. And typically, I don't know if Kamal a big fan of, so very share the same. So yeah, proximal tibia is what we gone for, and the other 2 sides if we failed.
Okay, perfect. I just want to make sure I didn't have the wrong information out there as an option.
But my own rule is with IOA, I do what I'm comfortable doing in the moment of the of needing it. So I don't want to try to do something that I haven't done before unless I have to. Like if I'm unable to get the tibial, then this is the time I'm going to be looking for the humerus. Probably I'm more comfortable than the distal femur. So I say do whatever you're comfortable and trained to do, because getting access, is, as Dr. Lucy was saying, is life-saving, and get it in the best way you can get it. If I'm not going to try to get access in a location that I'm not comfortable just because I want to train myself at that time, I'll probably do it in the simulation lab instead. I just want to get access of this kid.
Perfect, thanks.
Okay, what other questions do you guys have? Some crickets.
Yeah.
I'm curious as far as pressors, what you guys have available to you in the ED, because I know typically an epinephrine drip isn't something that would be readily available, but I'm just curious like what your process would be at each facility, if it's something you can pull out of the Pyxis and mix up, if you have to wait for pharmacy to get it for you, what kind of barriers you guys see there. Anyone? Answer.
Anderson would call pharmacy.
Okay. And then what would typically be like your turnaround time? Is that something you guys can get pretty quick? Is it like a half an hour?
Oh, it's not a half an hour, but it's, relatively quick, yes.
Okay.
Is it similar to the time you guys get Levofed for adult norepinephrine, or is a little bit longer? I'm just curious.
For us, no, I feel it would be equivalent.
Longer? Sorry.
This is Christy at Community East. Anything that's pediatric, like antibiotics, anything would take longer for sure. Yeah. They have to confirm it. It's definitely a little bit more challenging.
Okay.
We would have to call the pharmacy. That's pretty much, we have a protocol in place where you can mix push dose pressors at the bedside. Would that be, I just think that there'd be a lot of resistance towards doing that in a pediatric patient. So we'd be calling pharmacy. It'd probably take, I'm guessing for the time you conceptualize the pressor to the time where you actually got it back, it'd be half an hour. But someone may correct me on that, but that's would be my perception. Similar to adults.
Okay, well, I had a case study, but we kind of talked about everything in depth. Can go. This was actually a transport that I went on a couple months ago. It's a very, very small community emergency department that had pretty limited resources. So this was the one that we actually kind of started last month, and we didn't really go through the treatment since we were going to talk about it this month. So I think everybody was pretty unanimous on, like, if this kid shows up in triage, they're just getting put back in a room right away. Had a pretty significant history. It sounded like a pretty sick kid. And then as far as initial assessment, when the kid had gotten to the ED, was lethargic but responding to pain. Respiratory was Kipnick on their baseline of a 1/4 liter nasal cannula. Stats were 87% and having some intermittent apnea. And then CV was modeled, had very poor perfusional extremities, delayed cap refill was like 5 or 6 seconds, and heart rate was 180. They did not have a blood pressure prior to our arrival because they didn't have a cuff small enough. So we kind of talked about what our initial stabilization would be. Establishing access would definitely be a priority, and I think they attempted IV access, but when we got there, they had an IO placed in the right tibia, so that's great. They did give 120 ml per kilo normal saline bolus, and upon transport's arrival, the patient was intubated because she was having that apnea, and they were currently bagging the patient because they don't have pediatric capable vents. They had obtained a glucose, but had not obtained any other labs and not detect. So on our arrival, the patient was pretty alert and looking around. We actually had to sedate her. We placed her on our vent. Lung sounds were clear, but a little bit diminished, but still was pretty tachycardic, had poor perfusion. Like I said, they had not obtained a blood pressure, and when we did it, my systolic was in the 40s to 50s, and the abdomen was pretty firm and distended. So as you can imagine, went ahead and obtained blood cultures. We got a gas and started antibiotics. We gave the additional 40 per kilo of fluid. And I did go ahead and push that through the IO, but we still were not able to obtain blood pressure greater than 70. We started PIV for additional access. I basically talked to my partner, and I know we chatted about this a little bit. We were each going to try once, and if we didn't get a PIV, then we were going to just start another IO to have additional access. And then I actually had called and talked to the Riley PICU, and they wanted us to start norepi at 0.02. And we put in an OG dissection to try and decompress the blood. And then got her here as quickly as we could. And we kind of had to titrate. Do you guys have protocols for pressor titration? Like, is it nursing driven? Is it something you have to go and discuss with the doctor? Or do you just titrate to keep systolic blood pressure greater than XXX? I'm curious.
For adults, we have protocols for nurse-driven titration. For peds, I honestly don't think we have any sort of protocols on that.
Yeah. Anybody else?
We're the same at Anderson. We have them for adults, but we would consult physician for peds.
Okay. Okay. All right. Does anybody else have any other questions or anything else I know we're just about at time here. Anything else they wanted to discuss? If you guys think of anything or have any follow-up questions, just shoot me an email. I can try to answer them or get you in touch with Riyadh or Kamal. So our next session is going to be September 19th at noon, which will be the third Thursday. And we will, so similar to the status, epilepticus ones, we'll kind of talk about QI. If anybody's interested in implementing protocols or flow sheets or anything like that, we can discuss that and kind of go over resources.
About sepsis.
About sepsis, yeah, specific to pediatric sepsis. And so it'll kind of be really dependent on you guys and what you want to chat about. And if you had anything in mind, or if you don't have something in mind but you want to do something, we can kind of help get you started. And as always, I'll send out the link to the recording for this. So if anybody wants to watch that was unable to make it, and I'll also send out that little survey if you guys don't mind filling out. If there's anything that we can do better, please let us know, because we're still kind of learning, obviously. Otherwise, we'll just see you guys next month.
Thank you.
Thank you so
Thanks,
much.
guys.
Thank you. Very helpful.
Thank you.
Thanks. Have a good day.
Thank you.